So I'm going to try to give a really quick overview of what we're doing. So my name is Daniel Chow. I'm an assistant professor in radiology, and going to introduce the team over the course of this talk. And the goal is to develop a COVID vulnerability scoring system with AI. And what do I mean by that? So just as a background, we know from early data from Wuhan and Italy that there are a subset of patients who tend to be more vulnerable. These are the patients that require intensive care, needing prolonged ventilator support, and ultimately are refractory to therapies. And there's a lot of good data that came out from these initial sites, but one of the challenges is that we're finding is that when we scoured the literature, we found about maybe 30 papers, and that there were at least 70 different, between 60 and 70 different lab imaging and clinical features that may or may not be associated with good versus vulnerable versus non-vulnerable populations. So immediately we recognize that challenge one is that there's just too much and very heterogeneous data. It's difficult, if not impossible, for clinicians to digest and integrate all of this data. And that kind of goes with what we know about big data for healthcare. The other challenge that we're already recognizing is that our populations are very, very different. Our population, if you look at the average age of admitted COVID patients, they already tend to be younger. This is an example of one patient who's a 30-year-old, and you can see that she has pretty bad disease. We also tend to be more sicker, and we have a very much more obese population. So already our populations are different. So one of the things that we wanted to do was look at the clinical, laboratory, and radiologic data and see if we can develop a machine learning tool that can identify who are the vulnerable populations, so that if a patient is coming to the ER or admitted, if we can have at least some kind of prediction or an early warning system to say, hey, this is a high-risk patient, maybe you can start an aggressive care more early, and then ultimately an aim 2 or phase 2 to put this on a web-based platform and allow this to be able to update itself in real time. Um, so this is a very, very cross-disciplinary effort. At the time of the submission, we had folks from medicine, pathology, radiology, AI, public health, nursing, computer sciences, regulatory and biological sciences. I see some of you here. Dr. Sahar, I think Khan is also going to be lending some of his infectious disease expertise as well. Um, and already from just doing the QA of this initial daily set of this data set, we've already had some early impact at UCI. So one of the things that we noticed was that labs were being ordered inconsistently, and so out of the formation, this led to one of the severity screening labs. And so this is just an example of a patient. Prior to that, you can see that labs were kind of ordered a little bit haphazardly, which makes it really difficult to digest this data for like an AI or big data project. And now after this, we have much more consistent ordering for these patients. The other things that we've been seeing is that there are number of comorbidities, at least in the Italian and Chinese data set, have been associated with vulnerable populations. And so we were able to create a new priority status to expand UCI Health testing to include those of multiple comorbidities. And the last thing, just to for at least for early impact, is that one of the investigators, Peter Chang, was able to reach out to his contacts at NVIDIA and are giving us access to their supercomputer server to use for this project. Peter, are you available online right now? Peter Chang?
Yeah, go ahead and stop your screen share.
Okay.
I'll go ahead and.
And so Peter's going to give a show where we're at so far in terms of like prototyping.
All right, so I'll be super fast. I know we're just about out of time. The first thing I'll point out is that Dan did skim over a little bit about the mechanics of how this study is actually being executed. So I will emphasize that Dan is leading a team of students to manually review the EMR records on a daily basis to get as much data as we can from every patient. So essentially that's kind of a remarkable feat, and we're going to open up that data set to the larger community here to do work. Now, based on that hard-earned data, we want to do two things, as Dan mentioned. The first thing is we want to do some sort of machine learning analysis, predictive modeling with the data. Now, given our initial small cohort, about 32 patients right now, you can see from this very simple PCA analysis that the data is almost perfectly linearly separable, which means that in our very small cohort, these two data sets are pretty easy to differentiate. Probably no sophisticated machine learning is needed at this point. As we aggregate more data, the idea is that we'll probably start seeing clusters of different cohorts rather than just two big buckets. And as you get little sort of smaller sub-cohorts that are localizing around each other, that's when sort of machine learning will help and identify the different sort of phenotypic patterns of expression. Now, in terms of the second aim, let me see if I can do a really quick screen share, switch, share. All right. So we do want to create a web-based tool. So this is something I put together in just the past few days. Pretty straightforward. So taking some of that predictive modeling and making it available. At baseline, I will say the risk of ventilator in our first output here is already 10%, indicating that the baseline patient here, a patient that's sick enough to warrant labs and is in the hospital, has some baseline risk factor already. And as you can see, if I start putting in more and more risk factors, you'll start to see a gradual increase in risk. Again, I'm not a clinician, so I'm sort of just plugging in random values here. A radiologist probably is not the right person to be doing this, but you get the point that you can gradually see sort of the percentile of that input and an ultimate predictive model live in real time. And so the useful part about this is that not only do we have a mechanism to present these results, so this website will be live in just a few days, but most importantly, all those values that I just entered are being recorded and archived in an anonymous database. You'll see no patient information available here on this portal. And so once this website goes live and is accessible by many different institutions outside of our own, the idea is that we can take that data and reuse it and continue to improve the model almost on a daily basis, perhaps continuous basis over time. Okay, sorry, I know that was just a little bit long, but hopefully that was informative. And we'll probably open the floor up to questions.